Hi, my name is Ty Sabe, and I am one of the lead respiratory therapists here at Providence Regional Medical Center. I've actually been in respiratory care since 2001 here at this facility, and I've been asked to talk about our ventilator with this whole COVID-19 going on. There is some concern out there. Our nurse is going to be asked to manage the ventilators. And we're not going to ask you to manage the ventilators per se, but there is a couple things we'd like you to know what to do in case there's an emergency and until respiratory therapy can get there and help with the situation. Because as you know, when a patient is on the ventilator at this time, we are not going to be taking them off to bag them, whether they're a rule-out COVID patient or a COVID-19 positive, because we don't want to aerosolize the room and expose people unnecessarily. So there is some things that we might ask the nurses to do until we can get there, but we're not going to ask you to change tidal volumes, respiratory rates, or anything like that. But there is some cool little things that you'll be able to do to ease your mind until we can get there. So a couple things with the ventilators. Well, what if your patient starts to desat and you don't know what's going on? And you call respiratory and you say, hey, my patient's oxygen's dropping, I need you to come, and they're tied up with another patient in a positive room. There's a couple things as a nurse you can do. On the left side of the ventilator, there is an Fio2 button, and basically it says O2 right below it. And how you would change that to get 100%, you would touch it, it's going to get yellow, and then you have to use this knob on the right bottom side of the ventilator and turn it all the way up till you see 100%. When you see the 100%, and this is the important thing to do, you have to confirm it. If you do not confirm it, it would stay at 100%, but you want it, by confirming it, you're double checking and making sure that it's 100%. The caveat to this is if you're at 100% and you want it to drop the Fio2, say they start to oxygenate better and things are turning around, and I drop it to say 50%, on the dial, if I hit it here, it's going to automatically default back to the last setting, which would have been 100%. So you think you dropped them to 50%, but they're actually at 100%. So a good rule of thumb is what I tell all the nurses and stuff like that is, once you make a change, you're going to confirm it there with that button. And that's how you would change that. Another way to get 100% oxygen is you can hit the O2 suction key. Now right now, because the ventilator isn't set up into oxygen in the wall, it's going to be grayed out. But when it is on, you're going to see it, it's going to look just like these other tabs. You would hit that, and then you're going to confirm it. Now, with the O2 suction, you have 180 seconds of 100% FiO2, so 3 minutes. The beauty of that is if you don't want to fiddle with turning this up, you're just going to hit the suction key and confirm it. You know they're getting 100% oxygen. Give some time for the RT to get there. But then after that 3 minutes, it's going to default back to whatever you had set on the ventilator. So just keep that in mind. That's an important part. Let's talk about suctioning a patient who may be a rule-out or COVID positive that you are taking care of on the floor. One of the cool things about the ventilators is not only will the O2 suction tab give you 100% oxygen for 3 minutes, before you suction any patient that is on a ventilator, you want to make sure you give them 100% FiO2 and confirm it, because what this does is it decreases the risk of vagal stimulation, and it also will help increase with their oxygen. So you don't, when you suction, you do take the chance of taking oxygen out of their lungs and they could desat. So you always want to pre-oxygenate your patient before you suction, especially on the ventilator. Again, after 3 minutes, it will default back to your prior setting. So that's something to keep in mind. Now also keep in mind is if your ventilator, remember we hit the Fio2 key, turn it up to 100%, and then confirm. If the patient's already on 100% FiO2, you do not have to pre-oxygenate on the suction button, because you're not going to give them 200% oxygen. They're at 100%, they're already going to get the 100%. So that is something you do not have to worry about. A couple things on the ventilators is you will have a tidal volume set. Again, we're not going to be asking you to change those tidal volumes. You will have a respiratory rate set as well. Again, we're not going to ask you to change that. But it's nice to know that if your patient, say, is on a rate of 10, remember I turn it and confirm, and say I had a tidal volume of 500, I turn it and you confirm, they're getting 10 breaths a minute at a tidal volume of 500. In other words, how big of a breath they're taking in and out. So they're basically getting a breath every 6 seconds. 10 breaths a minute into 60 is 6 seconds. So they're getting a breath every 6 seconds. One of the other things you could also get with these ventilators that may be happening, if a patient is not sedated properly, or they could be coughing, or maybe they do have a lot of secretions, you could be getting pressure alarms with the ventilator. And they can be annoying at times, but sometimes there's easy fixes. Patient needs to be suctioned, we will suction the patient. That could cut down on the secretions. If patient's coughing while the ventilator is giving a breath, the breaths collide basically, and you're going to get a high pressure alarm on the ventilator. A couple things. High pressure alarms don't always necessarily mean something is wrong, but it does mean something needs to be looked at. It doesn't mean the lungs are bad, doesn't mean you have a pneumothorax or anything like that. But when you get a high pressure alarm, it's your first clue that something is going on. So when you have high pressure alarms on ventilators, there are numerous things that could be causing it. But percentage-wise, usually it's the patient itself causing it. They're not comfortable on the ventilator, so they could be coughing. They may not be sedated properly, so as they're trying to get, the ventilator's trying to give a breath, they may not want it. Or it could be as simple as sometimes the tubing can get kinked, or the ET tube could fold over and kink off. So what happens is the ventilator on the inspiratory circuit here tries to give a breath, and the ventilator only knows that it's meeting resistance. It's not getting to the patient. So the ventilator's not smart enough to kind of figure it out. So it goes back to the ventilator and you get a high pressure alarm. So sometimes if it's a kinked tubing, you unkink the tubing. Patient needs to be suctioned. We can suction and clear the secretions out of the ET tube or out of the patient's lungs. That sometimes will help. Or sedation is your best friend a lot of times when they're on ventilators and they're pretty sick. I like to tell nurses, or ask nurses, when you're sick, what's the one thing you want to do? You like to sleep. You just want to be left alone and rest. But when we're in the hospital, we're kind of doing just the opposite. We're always kind of poking and prodding the patient, trying to do different things. And so if you can have the patient rest as best as possible, that's reasonably allowable, then your life will be a lot easier on the ventilator. They'll be able to get volumes in and volumes out real easy. You'll be able to ventilate the patients and be able to oxygenate them better. Because when patients are on ventilators, they can at times clamp down, and even though the ventilator is trying to give a breath, they're mad, they don't want to take a breath. You may not see any volumes go in, the oxygen could drop. I like to tell nurses, patients are sick. That doesn't mean they don't know what's going on around them. They can hear what's going on. All they know is they have a tube down their throat and they're choking, and sometimes they don't understand that. So that's just enough to get a patient really aggravated and fight you at all costs. It doesn't mean they want to, they just don't know what's going on. So sometimes sedation, if you get them sedated, it'll make life a lot easier for you. On the ventilators, you're going to see they're set up, usually they can be set up differently, but you're always going to have a peak inspiratory pressure, and you're always going to have a plateau pressure. Now we were talking about the pressures on the ventilator. The peak inspiratory pressure, if that is high, that's a resistance issue. Notice something is resisting air to get into the lungs. RTs, if they're having high pressures and you can't account for it for, say, secretions, patient coughing or kinked tubing, everything is should be normal. You want to check a plateau pressure, and what that RT will do a plateau pressure, which is an inspiratory hold. They do a breath in, and that's kind of measuring the compliance of the lungs. That's your compliance. If your compliance is high and your peak inspiratories are high, they're kind of going to be the same, then it could be a compliance issue. It could be a lung issue. But usually if you're doing a peak inspiratory hold, peak inspiratory pressures are high, and you do an inspiratory hold and your plateaus are normal, then it's all resistance. Then really your lungs are okay. Something else is causing those pressures to be high. But it also could be everything's fine with the patient, my pressures are high, but sometimes you'll get a volume not constant on top of the ventilator, and it'll be red, because red alarm means, hey, I need to look at this right away. Red, don't ignore it. Yellow is kind of, hey, there's an alarm, but red is urgent. So if you're getting a volume not constant on the top, a lot of times it's as simple as the alarms on the ventilator are set too tight or too low. So the ventilator is giving a breath, the pressure alarm is set really low, and it's hitting that pressure right away, so it doesn't even have a chance to give any volume to the patient. So you would want to check the alarms, and again, we're not going to ask you to set these alarms, but it is something you could say to the RT, hey, are the alarms set too tight, or are the alarms set properly, would be a good way to do that. Because if your pressure alarm is set too low, the ventilator will not even be able to give you the breath that is set. So that could be one issue. And I see it a lot. It does happen because in an emergency, we get the patient intubated, you get the settings all set up, the rate set up, and the tidal volume. Sometimes the alarms kind of are an afterthought till like after we get the patient all settled. It doesn't mean they don't get set. It just might not be right away. So if you've got the patient on the ventilator right away and you're getting all these wacky alarms, and the patient's sedated properly and they're riding, they're just comfortable with the ventilator. It could be just as simple as changing an alarm for the RT to change the alarm. Okay, there's a couple other things I'd just like to talk about on the ventilator. And again, I want to stress, we're not going to ask you to manage any of these settings on the ventilator, but I do feel it's important to kind of know where they're at and what they have the potential to do for the patient. What we have here down here on the right bottom is PEEP. It's called positive end expiratory pressure. And basically the way I like to describe that in easy terms is it's kind of the end expiratory pressure that's left in your lungs, so your lungs don't fully collapse every time. So I like to think about it as kids. We buy a bag of balloons, we take the balloon out of the bag and we go to blow it up. And at first it's really hard to blow up that balloon. But at that point, that balloon reinflates real easy. I kind of like to think about that as PEEP. That's where PEEP is in your lungs. It's just easier to get inflated. If you have patients who are COVID positive or rule out and they're requiring high oxygen level needs, you're probably going to see a high number down here in the PEEP. And PEEP is only for oxygenation. It's not going to help a patient offload CO2. It's not going to help them give them a bigger tidal volume, but what it will do is help improve their oxygenation. It helps decrease the shunt so we can get oxygen from the lungs into the blood a lot easier. So PEEP just helps decrease shunting of oxygen getting into the blood. So it basically narrows the distance from where oxygen's getting from the blood or getting from the lungs into the blood. Usually when you have high levels of PEEP is usually your sicker patients. Now when I say high, 12, 15, 20 of PEEP, that would be significantly high for a normal patient, and that would mean they're needing higher oxygen needs than normal. It doesn't mean you wouldn't have a CHF person who has some fluid on 10 of PEEP, but I'm talking in the higher levels of 15 or so. Also, if you're already on 60% FiO2 of oxygen and the patient's not improving, we usually we call that refractory hypoxemia. So in other words, it doesn't matter how high we go up on the FiO2, we're not improving the oxygen on the arterial blood gases. So we have to figure out another way to help oxygenate the blood, and PEEP is one way that we do that. So the rule of thumb is if you were to get a blood gas and your PO2 is 50 or less and your FiO2 is at 60%, we would call that refractory hypoxemia. And then at that point you might want to think about going up on the PEEP to help improve that oxygenation. Again, we're not going to ask you to do that, but that's something that the RT and you should be communicating about if you're not improving your oxygenation and things like that. One contraindication, but one side effect of PEEP is that as you go up on your levels of PEEP, it will increase the overall airway pressures on the ventilator, so your pressures could come up inadvertently as well. The other thing you have to be careful with PEEP is if you have a patient who's hypotensive already and you increase levels of PEEP, they could become more hemodynamically unstable. But the caveat to that is if you have a patient and everything's fine, and then all of a sudden you go up on PEEP to help with oxygenation, and then all of a sudden they become hemodynamically unstable, you got to kind of think about what caused that, because you don't want to manage your patients a way that isn't necessary. So you're thinking they're hemodynamically unstable, so you're giving medications for low blood pressure when in theory it was just going up on the PEEP. So it might be just as easy as backing back off the PEEP, and then their blood pressure will come back up to where it was. So it's kind of a balancing act of just communicating with the RT and knowing, are they hypotensive before I went up, or they were fine and then I went up on the PEEP and then they became hypotensive. So it does happen. I have seen it happen. But on the sick patients, sometimes they're hypotensive and they can't oxygenate. So you kind of have a double whammy, and you got to kind of just balance it to what's best for the patient. There is an inspiratory time button. Again, you're not going to have to change it, but the reason I like to talk about it is sometimes patients are uncomfortable on the ventilator, and we can't understand why. Well, it could be as simple as some patients want to breathe in, they want to breathe in a little faster, some want to breathe in a little slower. But if we have an inspiratory time where the patient's not getting the breath quick enough that they want it, that will make them very uncomfortable, and they may fight the ventilator and they're going to try to suck through that breath. So again, we think, oh, we need to sedate the patient, they're uncomfortable, but it might not be that they need sedation. We might have to make a couple tweaks on the ventilator to make them more comfortable on the ventilator so that they're more in sync with it. Same with tidal volumes. You know, some people require a 400 milliliter tidal volume, some may take 600. But if I have a patient who's set at 400 and they're sucking through the vent and trying to take a 600 tidal volume, again, we think they're uncomfortable, so we sedate when maybe we just need to give them a bigger tidal volume on the ventilator. So each patient's going to be different, and that's something hopefully the RT is kind of talking to you about and managing that with you. And what I like to say too is if you have any questions about the ventilator, or if you don't understand something, that RT should be taking the time to explain to you why we have this a certain way, why the tidal volume might be set at only 500 when it's a big person because of maybe at the risk of ARDS, why the PEEP is only set at 8, things of that nature. So there should always be some communication with the RT. You're never going to be, I would like to think that the RT's not going to say, here's the settings, I'll be back. Any questions, call them. They should answer your questions about what's going on. Again, the biggest thing for nurses is if your patient starts a DSAT, what do you do? If you don't want to muck with the O2 suction button, you just come over here and turn your FiO2 up all the way to 100% and confirm it. And that's the important part. You have to confirm it. Now keep in mind, once that's at 100%, after 3 minutes, it's still going to be at 100%. It's not like the O2 suction button, where if you hit that, confirm it, you're going to get 180 seconds of 3 minutes, or 180 seconds of 100% oxygen. This will be at 100% oxygen until you turn it back down. So like anything, good, you can get too much of it. Oxygen is a drug, you got to keep that in mind. So too much over longer periods of time is a bad thing. You know, we all have nitrogen in our lungs and it kind of acts as a placeholder, but with 100% oxygen over time, you could actually flush that nitrogen out, and you can actually cause parts of your lungs to kind of collapse. We call that reabsorption atelectasis. So it's just something to keep in mind. Back in the old days, they used that back to kind of fix small pneumothoraxes after surgery. Some of the old docs did. They would put their patients on like 7 hours of 100% oxygen. Hopefully it would fix the pneumothorax. But so just keep in mind, yes, oxygen's good, but like anything, you can have too much of it over time. Our COPDers, we have to be careful with that, right? They chronically live at hypoxic numbers. So maybe 100% oxygen for one COPDer might not be a good thing. Now I would like to say this though, not all COPDers are retainers. So when in doubt, give them the oxygen. Always remember, hypoxemia kills, hypercarbia happens. The hypercarbia is going to happen regardless. We can do that. We can get the airway secure. We can start ventilating. But if they get very hypoxic and they code, they go into cardiac arrest, that's a whole different set of problems that we probably don't want. So remember, not all COPDers breathe hypoxically, and they're not all retainers. So you don't want to deny a COPDer who isn't a retainer oxygen when they need it. So when in doubt, if you have any question, put them on 100% oxygen, and we can figure it out from there. We can get a blood gas, we can do all that stuff. So just, that's very important, and I tell that to all the ER nurses, I tell that to any new nurse or any nurse that isn't used to dealing with ventilators, because there is some confusion out there. Oh my God, they're COPD, or don't give them oxygen. That's not necessarily true. You know, we always say SAT's 85 to 92%. Every doc has a different range, but just remember, not all COPDers breathe hypoxically, and if they need oxygen, you want to give. Do not deny oxygen to a patient if you're not sure. Just give it to them, and we can figure that out. So in summary, just with the COPDers, and if there's any doubt if a patient's hypoxic, put them on 100% oxygen until we can figure out what's going on. We don't want to deny a patient oxygen if they definitely truly need it. So, brings me up to this next scenario. If you have a patient who's in a rule out COVID room or a COVID positive room, what do you do if they're on the ventilator and they code? Well, in a normal person who's not in any kind of precautions, we call a code, and then we would take them off the ventilator, put the ventilator in standby, and then we would bag the patient appropriately, and then while chest compressions are going on. But with these rule out COVID patients and patients who are COVID positive, we have to handle it a little differently, right? Because we don't want to break the circuits on the ventilators and take the chance of aerosolizing everybody in the room, and we want to minimize our risk or exposure to these patients as much as possible. So as a nurse, you're not going to do anything with the ventilator. If the patient starts the code, they're going to stay on the ventilator. They're basically being bagged by the ventilator. We're not breaking the circuit. You're going to just do your diligence as a nurse, calling the code, getting the crash cart in there, or getting some help, and then the chest compressions will start. When respiratory gets there, at the first break, what we're going to end up doing is every time there's a break and you're doing chest compressions, we're going to put the ventilator in we're going to hold expiratory hold, and what that does is the ventilator stops giving a breath. You're going to do the CPR, whoever's doing CPR, and then after 30 compressions, we're going to let go of the button. They're going to give 2 breaths, and then we're going to hold the button again. You're going to do 30 compressions. We're going to hold the button on an expiratory hold, not going to get any breath. So basically we're moving to a 30 to 2, just like 2-person CPR. After the full 2 minutes, we'll do an expiratory hold. They'll check a rhythm, and if they have to start CPR again, they'll check. We'll start CPR, and we're going to do it all over again. So when a patient codes, you are not responsible for worrying about the vent. You do not break the circuit and worry about bagging the patient. They're already getting volume. They're already getting a breath. The reason we're doing the expiratory hold on the ventilators is because during chest compressions, the ventilator doesn't know you're giving chest compressions, and it may give a breath as you're trying to give chest compressions, and it can cause a lot of interthoracic pressure, which can cause damage and have some other problems for us. So during a code, your responsible is call the code, get everything you need for the code, get your personnel together. The ventilator will take care of itself until RT gets there, and then we'll take over doing all that. If the circuit should happen to fall off during a code during chest compressions, just put it back on right away. We want to minimize any kind of exposure as best we can. Sometimes if they're on heated humidification on the ventilator, that could come off. But during these COVID rule-outs and COVID positive patients, we're actually using dry circuits. So we're not going to have that problem. There's no humidification going through these circuits during this time. So that shouldn't be an issue, but they do come off sometimes. They could loosen, just FYI. All right, I'd like to talk about, we talked about some pressure alarms if you get a high pressure alarm, but what if you get a low pressure alarm on the ventilator? Or if you notice the volumes on the ventilator aren't matching what's set. Usually what that means is there's a disconnect somewhere or a leak. It's not urgent, but it's something that needs to be dealt with as fast as possible. If the patient's not getting any volumes, then we need to figure out why. So that's something that you'd want to call the RT right away and say you've lost volume or you're getting a low pressure alarm on the ventilator. Maybe something became disconnected, or look at the ET tube. Sometimes if you hear a bunch of noise and you get a low pressure alarm, it might have something came off the circuit itself. But usually when you have anything low, it means it's losing pressure or it's losing volume to something. So we need to look at that and get it dealt with right away. I'd just like to say that we all come from different clinical backgrounds. We all have different levels of clinical experience. Some have ICU experience, some have ER experience. Some may not have that much experience at all. They could be new nurses. So what I'd like to ask is that as nurses, don't be afraid to call your respiratory therapist and ask for help. There is always a lead therapist on shift 24/7 that you could call if you're not getting the response or maybe feedback that you need from your RT, or you're not comfortable with the answers or the help you're getting. Please don't hesitate to call your lead therapist. And as far as the clinical experience that goes with different nurses, keep that in mind when a nurse says, hey, I'm nervous about handling a ventilator or being around a ventilator, because not everybody, what we don't know can make us uncomfortable. So it's sometimes just a matter of having it explained to them, and as they play with it and know that it's going to be okay, they get more comfortable with it. We've all been there, we've all been new nurses, and we all, again, have different levels of experience. So try to help each other out during this time, especially if you have ICU experience. Take that time to educate a newer nurse on the ventilators, and what to look for, maybe not what to look for if you know. But again, don't hesitate to call your RT during this time. And again, the lead is always available for questions. I myself, if you call me, I'll come up, answer questions, go over the ventilator with you, whatever you need, ABGs, oxygen, whatever you need, we'll be available to kind of help you out with that. So hopefully this help you and give you a little more, make you a little more at ease with the ventilators, and know that we're not going to ask you to change anything on the ventilator as far as tidal volumes and rate, but just know the oxygen and what certain alarms could mean. Thank you.